Hi, good morning, everyone. Welcome to our competition 19 launch event this morning. We're very excited to launch this competition with, this is a new approach for SBRI Healthcare, supporting mature innovation. I'm Fanny Burrows. I'm leading on the SBRI Healthcare program, and I'm really pleased to be able to launch this competition today. It's a new call for the program, and we really look forward to giving you more information about this new funding opportunity. Next slide, please. So thank you very much to everyone joining us today. We're recording this session so we can make it available afterwards and also share a copy of the slides. You will have an opportunity to ask questions to our speaker, excuse me, during the session through the Q&A box. And we will answer some of your questions, some of them live and some of them we can answer directly through the Q&A box. There's a lot of information that is also available on our website, and you can find there the challenge briefs for each challenges that are addressed through this competition, but also further guidance for the prospective applicants. So next slide, please. I am joined today by some wonderful speakers that'll give you some insight on the competition and also the challenge, as well as the support that is available from the Academic AHSN Network. We've got our joint program director, Mike Lewis, that is here to give you some information about the program and this competition in particular. And then we'll have the pleasure to hear from Professor Tim Kendall, the National Clinical Director for Mental Health, NHS England and NHS Improvement, and Mrs. Katie Hiney, the Consultant Biochemist and Point of Care Testing Specialty Lead. We'll have a dedicated Q&A session with Professor Kendall and Mrs. Hiney. And after that, we'll have Carol Spencer that'll talk to us about the AHSN Network and the support they can provide. And finally, we'll have Zee from the Program Management Office that'll talk us through the assessment plan, the criteria for the assessment for this competition, as well as the application process. And we'll finish with a Q&A session about the competition or anything that is related to the program, the application, or the support available from the AHSN. We also have a wonderful Program Management Office team in the background that's supporting this event, responding to your question. We've got Alice, our events manager, Sandra, a senior program manager, and also Aisha, a program manager. So next slide, please. So now without any further delay, I would like to move to our first speaker. And please let me introduce you to Professor Mike Lewis. Mike is our joint director for the NIHR I4I and SBRI Healthcare program, and that's the industry-focused research arms of NIHR, NHS England, and Improvement, respectively. So Mike is Professor of Life Science Innovation at the University of Birmingham, and he has extensive industrial background in life sciences, digital innovation, and previously held senior roles at multinational companies. He's worked for numerous private equity and venture capital organizations, and today is chair of 3 life science companies. So Mike, welcome, and over to you.
Thank you very much, Fanny. I appreciate that. If you go to the next slide, please. Thank you. I'm going to try and introduce you, give you a short introduction to the webinar today, just to really go through what you're going to hear, how to interact, as Fanny's mentioned before, and also talk a little bit about innovation as well. You probably saw from the introduction, the kind introduction that Fanny gave you there, that one of my day jobs is I work 2 days a week as a professor of life science innovation at the University of Birmingham at the med school. So I deal with innovation every time I'm up there talking to people about different innovations. And the reality about innovation is everybody expects innovation to be, as it is on the left, a nice straight road with clear processes. But if you look at innovation in its reality, and I've worked with multiple startups, innovation is really complex. Innovation is not linear. Innovation is highly convoluted. And most of all, innovation is very frustrating as well, because you get to one stage and you realize that you missed something out before and you have to backtrack as well. Innovation is, if innovation was easy, I'm sure they wouldn't like people like myself talking about it at universities to people. Next slide, please. Thank you. Look, if there's a landscape of funding out there, there's all sorts of institutions are involved in different stages of funding. But what we did is we try to find, in fact, our job is to look at you as you go through your journey. And we found, speaking to lots of stakeholders, lots of people in HEIs, trusts, and also in SMEs as well, that there's a gap in funding in the SBRI Healthcare program. SBRI phase 1 at 100,000 takes you to a certain step. SBRI phase 2 takes you through to clinical evaluation. But then there's a gap, which is the gap between when you build something and you're searching for real world evidence, and then you getting it adopted. Now, the adoption thing is another area, which is all about procurement. But we were looking at this implementation stage. And if you're an SME or if you're a startup, what you tend to do there is you tend to look for people like angel investors, as it says down the bottom. And having been through quite a few, worked with a lot of angels, the first time you give away equity in your business is the most expensive time to give away. It's a time as well where you're closest to procurement, but your ability to realize value and see what the value of your innovation is at the lowest. So we created a new pot of money, a new phase of the SBRI competition, which is called phase 3, which is all about taking you through from your clinical evaluation and showing something works to showing that it works into real life. So as Fanny mentioned, this is a new pot of money that we're talking about. Next slide, please. In case you didn't know too much about the SBRI, I'm going to do a quick update on that. When the slide turns over, there we go. If you don't know too much about SBRI, SBRI is part of and it's funded by NHS England and NHS Improvement. It is an English-focused innovation agency, and it's a way that the NHS engages with innovators wherever they're from, HEI, trusts, social care, community care. It's a way that we engage with those innovators to try and drive innovations into the NHS itself, either to improve patient care. Particularly this competition, we're talking as well about increasing efficiency in the NHS. And it's a way we try to get innovations accelerated. It's just one of the tools that we're trying to use in NHS England to accelerate those innovations, to meet some of those real challenges, particularly today post-COVID we have, and some of the unmet needs we have. If we can find innovations through SBRI and through NHS, which we can also export and use to generate wealth for the country, help create a nice tax base, maybe make some products as well and manufacture them, and all help with the economic part of the economy, that's also a good thing as well. Next slide, please. You probably saw at the bottom of the slide before where it said AHSNs. AHSNs are our partners in this idea of bringing innovations to life. They help us deliver, they help us encourage innovation, and they work very closely with us. In a lot of areas as well, we seek advice and guidance from the AHSNs about what to do, which areas to look at, which areas of focus we have. And Carol's going to talk a little bit more about the AHSN network after me as well. So I'm going to leave that bit to her to talk about. So if we go to the next slide, looking at the funding we're talking about, how does SBRI fund things? Well, it is a source of early funding. And a lot of businesses either go to friends and family to try and get funding early on, or they go to, later on, as I said, they go to angel investors, they go to some of the VC funds out there, which is very expensive. But this is a source of early funding, very well suited for SMEs. And what's really interesting about the SBRI Healthcare funding is it's got a fairly healthy appetite for risk. We like things which are pushing the edge and having a look at things which haven't been done before. We like to take on that risk, and we realize that if you had to go outside for funding for risk, it would come at a high price. So this is a way to go for a risk and get early funding. It's also a simple process as well. I work across a lot of grant funding bodies, from BASE to MRC. The SBRI Healthcare is one of the simplest application forms that's out there.
Just wondering if hear my voice at the moment.
Oh, yeah, you're back.
Okay, sorry, we had a little drop there. So it is also a simple form, simple application. It's supported by the AHSN networks. If you go to the next slide, please. So what do we fund? The cool things about the SBRI funding, unlike some of the grant funding out there, it funds 100% of the cost, including VAT. And those costs can include labor, your subcontractors, your travel, your subsistence. It's one pot of money. And how do you contract with that? Well, For the legalese amongst you, this is a pre-procurement process. So it's a very simple process. But what we do is we have one applicant, and that applicant can have partners as subcontractors, and then you pay those partners as subcontractors. So we're just dealing with one end. Behind it is fairly light touch. So we call it light touch because it's risk-based. If we do face-to-face meeting, you build your innovation. Next slide, please. Thank you. So why did we come up with phase 3? We came up with it because we listened to people out in the market and they told us about this gap. We listened to people as well, and we chose the topics that we've got 2 topics to look at in phase 3, and we'll mention them quickly in a bit. But we chose those 2 topics because they're where the people told us to focus some cash in terms of innovation. We made phase 3 based on a lot of stakeholder workshops as well, independent from phase 1 and phase 2. It's not a sequential funding program where you have to do phase 1, meet the milestones, hit phase 2, meet the milestones to get access to phase 3. This is a standalone piece of funding which you can drop straight into phase 3, and it's there purely to support you gathering evidence and to get you through to that position where you can get procurement, widespread procurement across England, across the UK, and if you can get export, as I mentioned earlier, that would be even better. Next slide, please. So what is phase 3? You can apply for a project which can last up to 9 months, and the maximum amount of money is £500,000. And really with these entry points and exit points, what we're looking for is we're looking for some sort of evidence that you're getting traction. And that can be regulatory traction. It could be in use in a one trust somewhere. You've got your efficacy, you've got your safety data demonstrated. Obviously, it depends whether you're looking at a device, a diagnostic, or some intervention. Your entry point might be slightly different, but we want your entry point to be you have some traction. What you want to spend your money on the project can be a study, some refinement of your technology, so maybe some code writing, could be a health economic assessment to look at the overall economics. And it could be just to look at the outcomes as well and just some statistical work on the outcomes. And what we want you to have at the end of it is you to be able to say to a procurer, here is evidence that this works. Here is evidence that we're working in collaboration and partnership. And here is evidence that there is an economic driver for adopting this innovation. Next slide, please. The 2 competitions I mentioned before are probably 2 really interesting ones. We all know the burden that's been placed on the mental health services because of COVID-19. So one of the challenges we're looking at is, and the wording's fairly specific about this, we're looking for mental health inequalities in children and young people. So we're looking where there isn't effective support, where the service needs improvement, where we need equity of access, where we're looking at communities that have been, for whatever reason, disadvantaged in some way in getting access through to mental health, which has created the inequalities. So that's part 1. The second part, also driven a little by COVID as well, is we're trying to follow the NHS reset and recovery agenda. We're trying to find new ways of doing things, because just looking at from the outside and the work I do with NHSX and NHS Digital as well, the way we used to work before is the old way. We need to find new ways of work. I have family members who work in the NHS, and they've come under enormous pressure as they've tried to do their jobs working in ICUs and working in trusts. There's been a lot of pressure on the NHS. So can we find new ways of working that will help reduce that workforce pressure? Because if you have sustained pressure in the workforce, then you end up with a lot of churn, you end up with a lot of loss of educated, trained people, and you get a diminished workforce. On the other side is, can we find ways to improve how the NHS work, how effective it is, how people get channeled in different ways, and how we can do things differently. Next slide, please. I did see a question come up as we're looking there from ISA. Does this apply to social care? Yeah, we're trying to be as open as possible with this. Eligibility. The type of thing that we're looking for is, we're looking for devices, we're looking for digital health, we're looking for equipment, we're looking for interventions. We're not looking at drugs and therapeutics because it just takes too long to get those things. We're not looking for things that haven't been designed, developed with a lack of patient involvement. So I'm going to spin that around the other way. We want things that have been designed working with patient groups, working with the public, understanding citizens' needs. We're looking for things which are at that implementation stage. So we're looking for mature innovations, not really just trying to work out how things work. And just to answer a little bit of Issa's question, any organisation can apply. Public, private, third sector. If you're a charity, go for it. If you're a social enterprise, go for it. If you're a community interest company, go for it. If you're part of a trust or a special trust, go for it. Show us something interesting and new. And the type of project we're after something where we can generate evidence which will get you adopted and which will get you used. Next slide, please. A couple more for you. Some key dates, just leave those quickly on screen. We're launching it today. That's the top one. You've got till 13th October to get that short form application in. Assessment is fairly clear. We've got the dates set aside in January for panel meetings, and all the people and panel chairs are all booked, ready for this one. So we're going to go at fairly quick speed on this competition. We're going to go start to end. It's going to take maximum 6 months till contracts being awarded. So that's very quick. Next slide, please. Just as a portfolio snapshot, this is just SBRI Healthcare before I pass back to Fanny. We've helped 74 companies. Half of those companies export their products abroad. About 70% of those companies actually sell right now into the NHS. Lots of patents granted. There's been some very big leverages of private investments as well. So this is the bridge to funding. We've helped nearly 7 million patients have been involved at some stage during the SBRI healthcare programs. So this works. It's one of the tools in the armamentarium that we'll have. So I'm hoping that phase 3 just adds another strength to this and adds another bow to this. So once again, I'm going to pass back to Fanny in a minute, but don't forget, put your questions into the Q&A box rather than into the chat box. If it's in the Q&A box, we can pick those up offline as well and send you answers, rather than the chat box, which we'll use just for commentary. So questions into the Q&A. And with that, I'm going to pass it back to Fanny.
Thank you, Mike. That was really interesting and really great introduction and overview, introducing this new phase 3 opportunity for the program. So that really sets the scene. And we're now going to hear a little bit more about those particular challenges that you mentioned, Mike, around the mental health for children and young people, but also the NHS reset and recovery. So now I would like to move on to our next speaker, and I would like to introduce you to Professor Tim Kendall. So Tim has been the National Clinical Director for NHS England since April 2016. And he also chairs a number of government and multi-agency committees to implement a national mental health strategy, but also leads programs that includes the impact of COVID-19, suicide reduction, talking therapies, but also things around digitalization. So now Tim continues to work as a consultant psychiatrist, but is also a strong advocate for the inclusion of people with lived experience, and also convened the first ever expert reference group for NICE, which included lived experience members. So welcome, Professor Kendall. Over to you.
Thank you. Okay, well, thank you very much for asking me to join you for this. It's a very important area. But perhaps I'll give you a very brief summary of what I think the position is. Now, if you look at the whole of the health burden across society, 28% of that burden, so whichever way you look at it, whether it's economic or quantified in different ways, quality of life or whatever, 28% of that health burden is a direct result of mental health problems. And yet mental health probably only gets around about 10% of the funding for the NHS. So there's huge inequalities around mental health itself. Now, to put that into perspective, or perhaps make it more concrete, when I started in 2016, we were actually only seeing, so the NHS were actually only seeing 1 out of 4 children that had a mental health problem. And it's a bit of a gamble as to who would get that help. You know, it wasn't just that children who had severe problems got seen, but those with mild and moderate problems didn't. In fact, it was across different levels of severity. So imagine how unacceptable this would be for me to say that 1 out of 4 children with cancer actually got help. Now, we have changed this and we've increased access so that now we are at 40% of children, but that leaves 60% still not getting access. Now, to add to that treatment gap, it's worth saying that in terms of adult mental health problems, 50% of those problems have started by the time you're 14 years old, and 75% have started by the time you're 22 years old. So the fact that we've got this treatment gap in children is itself a major issue for adults with mental health problems. So that's one of the reasons why we have struggled and continue to struggle to change that. Now, in 2016, we had the 5-year forward view. We said that if we got an extra £1 billion to spend by 2021, we would see many more children. We'd see 1 million more people. And you can see highlighted in yellow boxes those bits where we said we'd do more for children. And you know, we said we'd change the number seen from 25% to, we said 35%. We've in fact we've exceeded that. We're up at nearly 40%. We also said that we would provide early intervention services across England, and that we'd see all young people who were developing a psychosis would start treatment within 2 weeks, etc. So there's lots of stuff. Now, all the slides that follow, I'm going to go through very quickly because I don't think we've got huge amount of time. So, and we can answer questions at the end. So next slide. Okay, so in 2019, we managed to get agreement that we would have within 5 years of that, an extra £2.3 billion per year for mental health in what is the long-term plan. But we also had agreement that within 10 years from 2019, that we would be making sure that 100% of children would gain access to mental health services. Now, one of the areas that we've focused on, which is particularly relevant given COVID, is eating disorders. Eating disorders probably has a prevalence of around about 6%. It may be more, and that's excluding obesity. That's just eating disorders such as anorexia, bulimia, binge eating disorder, and other similar mixtures, if you like, of those different kinds. So we now have got community-based eating disorder services across England, and we're trying to boost those so that anyone with an eating disorder can get access to treatment starting within 1 week if it's urgent, within 4 weeks if it's not urgent. Now, before the pandemic, we were on course to achieving that by 2021, but there has been a virtual doubling of us taking young people into urgent treatment within 1 week. So that's put us slightly off course. Now, another area that we have expanded since 2018, we are putting we're putting in special teams called mental health support teams working into schools, and we're now reaching, I think, 3,000 schools have got mental health support teams in them, and we're planning to expand those further still. We've introduced crisis services, and by 23-24, we expect that every part of the country will have crisis services. Even as we speak, we've already instituted crisis lines, so that if you go to nhs.net nhs.uk/talk, and you put your postcode in, it will give you a phone number that you can access 24/7, and that's across the age range. We are promising that by 23-24 that we'll have a 4-week waiting time introduced across children's mental health, and we've got various other commitments around digital therapies and so on. Next slide, please. Sorry, next slide, please. That's it. Okay, so this is a bit of a repetition of what I've just said, but it gives you some of the details around finances and around the growth in spend across CCGs, and some of the details that you can look at in your own time. So next slide, please. Again, you can look at most of this yourself. I mean, the impact of COVID is pretty obvious. Children have suffered really significantly during COVID. We have had some real scares around the mental health of children, and that goes on. As I said already, eating disorders has virtually doubled in numbers of children coming through. But we've had big rises in the incidence of depression, anxiety, and other mental health problems. It's also true that it's been more difficult to access help, and so on. But the very things that, if someone has a mental health problem, the usual way in which people deal with these things is that they go to their loved ones, they talk to their teachers or people at work, etc., etc. Social distancing has kiboshed that. So the very things that you would normally depend upon have made that more difficult. And there are some areas where we think that what was already difficulty in accessing services for some Black and minority ethnic groups, that those difficulties have remained problematic, if not worsened. And those with special educational needs and disabilities have also suffered considerably during the pandemic, all for very obvious reasons. So what I should say is that we're I think the only country in the world that has real-time surveillance of children's suicides. So we have kept track on that. There have been some times where we've had big concerns, but it's important that we actually do have our finger on the pulse, and we track that week by week. Next slide, please. This just shows you the impact on prevalence, and there are two bits here. The first one is, if you look at the top left, you compare the prevalence of mental health problems in under 18s. Back in 2017, it was 10.8%. By 2020, so this is July 2020, and this is Office of National Statistics data, those with a probable mental disorder rose to 16%. So there's a clear rise during this period. And the second thing to notice is that in the same study, that the group that have suffered most over recent years have been young women. So in women aged 16 to 25, roughly, I think it's 27.2% now have a probable mental disorder, compared to only 13% of the same age group in men. Next slide, please. Again, this would just show you the gradual increase. So if you look at the graph at the top, There was an initial drop in March 20 in number of kids accessing mental health services. It took till about October of that year for us to get back up to speed. And since then, there's been a sustained increase in number of people coming into mental health services. Now, that's planned. We want more people coming into mental health services, but there's also an increase in demand. Next slide, please. I think we can skip this. We don't have time. It's just that we managed to get more funding into mental health services for this period to address the needs that have arisen with COVID. Now, on to inequalities. The big inequalities in mental health, the first obvious one is gender. There's a huge discrepancy between boys and girls, young men, young women. So as you can see on the left, gender of patients in community mental health, eating disorders, huge discrepancy, 90% just about are young women. It's the other way round for autism spectrum disorder, about 30% currently are women, currently are girls. In inpatient services, the vast majority are women. Next slide, please. And you can see that there are differences across different ethnic groups. We can talk about that, but I think the major issue with the ethnic groups is access, and that's true for older people as well as for children and young people. There's a strong tendency for people in different ethnic groups to not come forward to services. Next slide, please. Okay, so these are the sorts of things that we're doing. We've got an Advancing Mental Health Equalities Task Force, which was set up in February of 2020. And although their efforts have been made more difficult with the pandemic, they've developed local patient and carer race equality frameworks. They've engaged across England. There's access to what different things work. The long-term plan is focused very much on inequalities. One major issue that we've got is a difficulty in getting good data on inequalities, but we're improving. One area where we're clearly we have difficulties, which are for children and young people and older people with severe mental health problems. Their physical health is a major issue. And although we are making access to physical health assessments and treatment more straightforward, that remains an important and pressing issue. Now, finally, next slide, please. Finally, we're doing a lot in the digital health space. Which I don't know if the next slide has it on it. Well, it's got some. Okay, I'm gonna summarize because we're running out of time. Children, young people, major issue, mental health problems. As I've said, most mental health problems in adults start when you are a child. Lack of access to mental health services is a big issue. The inequalities that we need to look at, first off, are gender. Second, are Black and minority ethnic groups. Thirdly, kids with autism, learning disabilities. But socioeconomic factors underpin this. The response that we've got, and for all of you who are listening, if you've got innovations, don't think just innovations like digital innovations, having digital therapies, that kind of thing. They're important, but we need to think of this across where do you find children, schools, looked after children, families, social care, health and justice, and for those 0 to 25, so the 18 to 25 group in work. Now, as I've said, we have got services going into schools, but we need services going across into other parts. So that's my my take on inequalities in children. Back to you.
Thank you very much, Tim. That was a really detailed and insightful overview of mental health services, long-term ambition. It's really good to see, you know, the ambition and how, you know, you've managed to change those numbers. So thank you very much for that. Also really interesting to hear about the impact of the crisis on the children and young people, and also the variation across the different populations and the inequality that this represents. So that's really interesting, and I hope a lot can be done and continue to progress in that space.
No, indeed. I mean, it's the pandemic has had a major impact on the mental health of children, and widely this is understood. But you know, there has been a huge rise in kids needing mental health problems, mental health services. So innovations in this space are greatly needed.
Yeah, definitely. Yes, thank you very much. What we'll do is Tim, we'll come back in a moment. We'll hear from Katie first. We've got a few questions that started to come through, some interesting questions that we can pick up a little bit later. So to everyone listening, please continue to pop your questions for Tim in the Q&A box, and we'll be back in the Q&A sessions in a moment. So thank you very much, Tim. And now I would like to introduce you to our next speaker, Katie Hiney. Katie's worked within the NHS for over 15 years now, and has a background in clinical biochemistry and point of care testing as the point of care testing specialty lead and a consultant biochemist at Berkshire and Surrey Pathology Services. Also in 2020, Katie was seconded to the Department of Health and Social Care as the point of care workflow lead for COVID-19 testing operational supplies during the crisis, and for the rapid testing deployment to the NHS, a huge piece of work. Katie is strongly involved and passionate about the use of point of care testing devices to improve patient experience and also support the rapid diagnosis and treatment decisions. So Katie, welcome. Thank you for joining us today, and over to you.
Thank you very much, Fanny. Good morning, everybody. Fanny, can you hear me properly?
Absolutely, yes, thank you.
Great, thank you. Thank you for the introduction. I just want to state, in comparison to coming after Tim, I feel a bit inadequate here. But my experience here is based on my NHS role, has me responsible for 4 NHS trusts with 5 A&E departments, and all of that has come with that in the last 12 to 18 months, and seeing all of the services in those trusts and how they have flexed, how they have moved with the time that they were presented with and the patients coming through the door. And then also, as Fanny said, my secondment to the Department of Health has meant that I have had responsibility for liaising with NHS trusts across England, and some with the devolved authorities, and talking to them really about how COVID has impacted them and how rapid testing for COVID can help improve patient care, patient flow through hospitals and things like that. So that's where my experiences are coming from. My point of care testing is my passion. It's I really want to be able to use all of those devices in the best way possible to support patient care, to support faster diagnosis, but still maintaining quality results, still maintaining patient-safe decision-making. So I'm going to talk a little bit more on what Mike sort of went over about what is the challenge here really, and in diagnostics particularly, the impact of what COVID-19 has had on us. So you will have seen across the media, you will have seen if you've ever had to attend an emergency department yourself, the pressure that was put on the ambulance service, the emergency department, acute admissions and intensive care. And really diagnostics were used then to just move patients through those systems as quickly as possible, to cohort patients appropriately as to whether they were COVID positive, COVID negative, COVID not sure. There's been a huge amount of pressure on those services. It cannot be underestimated. And I will forever be in awe of the way those services flexed and changed. Could you go back to the previous slide, please? I thought it was incredible to watch, and the expansion of the ITU units, the way A&E departments Instead of just having the one front door where patients came in, they split themselves up and divide themselves up. And we will see more of that as winter comes and the other respiratory diseases start to play their role. There's also been a huge amount of pressure in general practice. Social distancing in general practice estate is even harder to do. Their buildings are much more limited in size. They often only have one entry point, for example. And so they've had a huge amount of pressure there. Their digital supports don't always accommodate every demographic. And I mean that by when I say from her personal experience, trying to get my daughter to talk to a general practitioner about the symptoms in her throat and her neck when she had a swelling over a video call just didn't feel the same level of healthcare that we used to have when you saw a GP face-to-face. So there's lots of pressure in the GP practice, lots to talk about how do you triage patients to get them in front of people when that's needed, and making sure that we don't just allow everybody to walk through that front door. It's just not possible at this time. Next slide, please. The other part of then the impact onto services, I'm hoping is going to come up on the next slide. When we get there, there we are, is about elective surgery and elective procedures. Some of those were paused, some of them were stopped. There's been a massive reduction in capacity. So you can see that looking at all the waiting lists have climbed. They've all gone up, lots of different scales there. The one at the bottom is in millions. So huge increases in waiting lists, but how do we deal with that? Can we ever catch up? And I think we've reached the point now where we need to look at different ways of working. We need to look at how we can get through these backlogs, not just following exactly the same path as we were doing pre-COVID. These waiting lists are enormous, and I think there's every expectation that they're not actually as big as they could be, because a lot of patients are still to be seen by the GP and then referred on to that waiting list even before now. So moving on, that's kind of the impact on those services, and diagnostics has a role to play in all of them. One of the most interesting parts of transformation that's taking place during COVID has been looking at these different ways of working. And you'll hear them discussed in terms of virtual wards, hospital at home, using video appointments for outpatients. The virtual wards are a way of expanding the hospital site effectively, patients being managed at home, or even being managed through care homes, but having observations taken, having point of care tests done by healthcare professionals who either visit them or are working in the institution they're staying in. And then those results coming back to the acute physicians at the secondary care site to be assessed and to be considered as to whether those patients need to come into the hospital for an escalation of care, or if they can remain at home and just be monitored. And we've seen those virtual wards and those hospitals at home start off with these smaller size pilots. They're perhaps only one ward worth. And we now need to consider, how can we scale these up? How can we do this on a larger scale for perhaps different patient groups? Which patient groups are suitable for these? Which ones can we still maintain that same high safety standard, but ultimately use it and work in this different way? All of those transformations require digital support. They do require a demographic consideration. For some patients, they feel, I'm unwell, I should be in hospital. But actually, we want to try and manage you at home as much as possible. And lastly, my bottom line here is these services must maintain their level of safety and quality that we would all expect from our NHS. Moving on, please. So this comes to the challenge then about the services, and ultimately the SBRI's challenge on this is to increase NHS effectiveness and looking at different tools that can help us manage that ginormous waiting list, identifying those patients that are on that list that need to be escalated. How do we pull those patients out? How do we filter them out from that list when we're under such pressure to continue managing it? So ensuring their symptoms don't escalate while they're on that waiting list into a point where they would perhaps have further complications. Making sure that we've given them all the diagnostics that they need before they walk in the front door. So pre-surgery, patients often have a set of blood tests done, for example. They might have their weight checked, they might have blood pressure checks, things like that. How do we ensure all of those are done before they come in for the surgery on the day? And not just done, but done successfully. And in diagnostics and pathology particularly, this is important. So I'll give you a very basic example. Somebody has a blood test done, and that blood test, the blood sample itself, if it is insufficient, when that comes into pathology, we will try our best to run as many tests on it as possible. But some of those tests we may report as insufficient. We didn't have enough blood to give a result on that. And that will go out on the patient's report. Now, a system, a stupid system, if you like, would see that as being resulted. They have a result. But an intelligent system would recognize that isn't a result. It's actually a failure here, and somebody needs to have another blood test done. So how can we have systems, and our challenge to you is find us a way of being able to intelligently assess the results for these patients to make sure everything is not just done, but successfully done. And that's really important to us. Next slide, please. The other part of this challenge then about NHS effectiveness is hopefully on my next slide. Goodness me, IT, here we are. Reducing the burden on NHS staff and administrative tests. So this automated process is important to us, but the bigger part here is about end-to-end connectivity. Now, what is this about? So if you are a patient in the community and you have a glucose test done, a finger prick glucose test, who needs to see that? There's the healthcare professional perhaps immediately in front of you. You may even be doing the test yourself on a glucose meter that you have been prescribed or given. And then that result, if that just stays within yourself and between yourself, how can your diabetic nurse practitioner then take into account that result and how you're feeling? How can that feed back to the diabetic consultant who is then doing as part of your annual review an assessment of all your glucose results? And ultimately, if you are acutely unwell and a diabetic, how can we get that result to the acute physician in ED who makes a decision whether you need to come in because perhaps you've got diabetic ketoacidosis? So this end-to-end connectivity is really important. It's about the observations and the testing done in front of the patient, wherever the patient is, but making sure everybody in the pathway is able to see those results, which if they can't, can mean that a patient has to have a test done repeatedly, or it can mean results are lost and perhaps patient's management or patient's treatment is delayed and we've not had the best outcome. So that end-to-end connectivity is really important to us. It's difficult to achieve, and we must remember all of the requirements for that data to be protected and to be secure. Okay, moving on. So the second part of what I was asked to talk to you really about is about NHS workforce. And again, I will talk to you about the experience that I've seen working at my 4 trusts, and then really my experience of working with all of the NHS pathology community during my time at Department of Health. And what we're starting to see now, the very senior experienced staff are starting to talk about their burnout. They're starting to talk about, actually, you know what, I was going to stay on for another 3 to 5 years, but I've realized that I can't, I'm tired and it's too much. And we have this bringing forward, if you like, of a number of retirements of very experienced staff, and that will leave us with a huge gap. We've also in this time had some incredible crisis leadership at trust sites, people who have stepped up into the fold, people who have been able to make those difficult and very rapid decisions to maintain services. And what we now need to move into is about recovery leadership, is about how do services get back up and going, how do we move through those waiting lists, but at the same time doing it with a load of staff who have this huge mental burden of all the work that they have done in the last 12 to 18 months. We have got overworked staff, a huge risk of burnouts, and while there are resources being made available to staff, we must ultimately also recognise that sometimes there is just have to be an acceptance that it will be time and patience that will allow us to move through that. And what we need to find are innovations and ways of improving the way that those staff work to help them feel like they're being more effective, to help them move through those waiting lists. And a recognition that a number of them will carry a large amount of guilt over their abilities or lack of abilities to be able to look after their patients in the last year. Agency and locum staff now have become very few and far between. They are in incredibly high demand, and in diagnostics particularly, almost impossible now to get hold of for pathology services. Next slide, please. Recognising that a number of this resonates with what Tim was saying in his previous talk about mental health aspects. I feel very underqualified talking while he's on the call about it, but I will continue. What do we have though? We have a lot of new recruits. We have a lot of people coming forward now, wishing to support the NHS, wishing to enter into a career because they've recognised how important it is, and we are ultimately a good employer. But those people need training. They need training, they need supervision from experienced staff. And those experienced staff we have in a limited capacity and in a limited amount. These new staff are not qualified or registered, so there is a limitation on the activities that they can do when they are not supervised. And it does take some years for a number of them to be qualified. 3 years is quite typical, particularly in the laboratory workforce area. We've got new and increased roles, and this is where diagnostics has really come into the fold. Can you believe that on BBC News, somebody even mentioned the words point of care testing at a 6 p.m. news conference, and I fell off the sofa in my chair. Children thought I'd fainted. This increase in COVID-19 testing is absolutely mammoth. You cannot understand the scale in which that grew up and has evolved and become. And we even now are still working on the scale of that. We are still working to improve the speed of tests, to have rapid tests for and a whole host of other things. But we have stood up what is quite remarkable in our NHS, this rapid COVID testing and high throughput COVID testing, thousands upon thousands of tests done on each NHS trust. But we also have continued doing all of our other pathology tests. We are still monitoring inpatients. We are still supporting maternity services. But there are some areas that have a backlog now. Biopsies, for example, patients weren't coming in for them. Smear tests, they certainly were not coming into GPs for those. And there are huge numbers of annual checks not done. Point of care testing is one of the biggest growth areas, whereby we now want to look at how can we help manage those patients even quicker? How can we get them in, do the test and move them on so that they don't spend large amounts of time on secondary care sites being possibly at risk of contracting COVID or any other respiratory diseases that might be coming upon us in the next few months. I can't not say anything about imaging. There was a huge backlog for imaging, reduced capacity, particularly about social distancing and physical capacity. So I absolutely take my hat off to all of the diagnostic imaging staff who are working through those backlogs at incredible speed and flexibility. But there is certainly a greater need for those staff and for that workforce for support. And community roles as well. There is an expansion in the need for community roles. We don't want to bring patients onto secondary care hospital sites unless we have to. And so we must find a way to get ourselves out there to visit those patients rather than bringing them into us. Next slide, please. I think my next slide is on the challenges, who we are, which is part of this SBRI innovation. This is about reducing the pressure on the NHS workforce. How can we help the workforce that we have got now to do their job better, be more effective, feel more effective? We need to look at, in our opinion, diagnostic and screening tools, ways to look at that backlog, look at those lists, prevent unnecessary visits to hospital by trying to get one-stop shop type services going, whereby a patient comes in and has everything done. And that does take some skill sets, it takes some data processing and organisation parts, and we need support with that as much as possible. Clinical assessments, things that we can do in the community, whether this is a medical device that you're thinking of, whether it's about a clinical assessment, whether it's bringing together several different pieces of information and looking for pattern recognition. But again, all with this end-to-end connectivity has got to be part of it. It's not good enough for us to continue on just using test strips or iRead devices, which we then can't upload electronic results on, that people can't see elsewhere. We need to get everything electronically into that one system. And that means the devices that you guys produce have got to be able to be capable of that, or you've got to help us by providing us with devices that can assist with that. Next slide, please. You can see that's where my passion is for point of care testing. Community diagnostics, like I said, the one-stop shop, looking at patients with long-term conditions, patients who need annual checkups, patients who need monitoring to make sure they don't escalate in their clinical condition. Looking at whether it's artificial intelligence, if you call it that, or just call it pattern recognition, but ultimately helping our NHS workforce to make those faster clinical decisions. Educational and training programs are really important to us. Notoriously in the NHS, we give it a go and we do a bit here and we do a bit there, but no one, in my opinion, has nailed it. Nobody has said, you know what, this is the right training program for us. It really works for us. Or maybe they might have nailed it at one site, but then that member of staff moves to the hospital down the road and they've got to repeat the whole thing all over again. How can we improve ourselves on this? There must be a way. I think that is the end of my slides. Thank you very much. I will have a look at questions or anything like that came up. I've put in a couple of references there. The first is the Diagnostics Recovery and Renewal Report, as produced by Sir Mike Richards, which has an entire appendix on point of care. So it's genuinely my favourite report out currently. And the second one there is the March 21 NHS Operational Planning and Contracting Guidance. Thank you very much for your time.
Thank you very much, Katie. It's really incredible to hear how the pandemic has affected the NHS so dramatically, and so much difficulties to recover from the crisis, and sort of how long is that going to take. So many opportunities really to be able to contribute to the recovery. So yes, I hope that sort of resonates with everyone. So now we're moving to our question and answer session with both Tim and Katie live, to be able to respond to some of the questions that came through the Q&A box. So to everyone listening, please do pop your questions here that you'd like Tim and Katie to answer, and then we'll have further opportunities to respond a bit more specifically about the programme later on during this morning session. And we also have the team in the background responding to specific queries. So I would like to start with a few, perhaps, some of the numbers that you mentioned earlier, Tim, during your talk. And we've got somebody asking about the 28% based, so you had a figure around 28%, and perhaps a question on what that was particularly based on, and whether the sort of DALYs would be a lower value if it were based on that. Oh, you're on mute, Tim, sorry.
If you take the total number of life years lost to disability and death, it comes out at about 28%.
Okay, I think that's probably good. And we had another one around the 6% prevalence for eating disorder, and a comment about the adult psychiatric morbidity survey and children and young people version that is lower, nearly around 1%.
Okay, they might be surprised to know that actually the adult psychiatric morbidity survey did not look at eating disorders. So there is no data from the APMS on eating disorders. I did I sort of ran the NICE guideline on eating disorders, and we pulled together a number of different sources of data around prevalence. The problem about prevalence is that you're not talking about one disorder. So, you've got anorexia, you've got bulimia, you've got binge eating disorder, you've got eating disorders, strangely called not otherwise specified, EDNOS. And the truth is that when you count all of those up, plus those who've got a mixture of them all, then you are up at about 6%. Now, in women, it's up at probably 15% of women have got an eating disorder. Yeah. Now, people might think, oh my God, you know, this is medicalizing, etc. But actually, I don't think it is. I think that we have a major issue, which is a public health issue about the constant bombardment of people with stuff around what kind of image you should have, what kind of, you know, what's the idealized body that you should have, etc., etc. And I think it's been made worse by social media. So I am not surprised at those kind of figures, shocking though they might be. And, you know, as I say, the pandemic has made this worse. And I think probably, certainly talking to service users, it's made it worse because eating disorders, for many people, not everyone, but for many people, it's a way of establishing control in your life. And, you know, it's been very difficult, the experience. So, yeah, so I think they're pretty reliable bits of data. And the APMS are going to include eating disorders in the future. We've been in discussions with them and I'm on their steering group, so it will be covered in the future.
Good. Yeah, that's good to hear. Brilliant, thank you. So perhaps moving on a couple of questions for you, Katie. And there was one around pre-operative and peri-operative assessment, and if you've got any comments around sort of assessment for that, and how we can expedite elective pathway with these assessments.
Thanks, Fanny. I mean, ultimately, there's another question in there as well about whether does a clinical assessment mean a blood test as well or not. And, you know, blood tests are, and I say this as a biochemist, no use in a single setting. If that's all that you have, there is very limited amount of decisions or you can make about a patient's care. You need to put it together with the clinical presentation, the clinical history, and everything else around that patient. And so absolutely, any kind of, when we say clinical assessments, I don't by in any way mean just blood tests. It needs to be the whole part of it. And for preoperative and perioperative assessments, anything that improves the speed in which we can do that, the way in which we can do that, the you know, expands out the grades of the people that can do that in order that they can then still be supervised by those who are qualified or registered, but ultimately enable more junior staff to take part in that process and support patient care would ultimately be an improvement. So I think that's all part of it as far as I'm concerned.
Okay, yeah, absolutely. Great, thank you. And then there was a question around the elective backlog. Would the estimate of 9 to 14 million elective backlog by 2022 still valid in your opinion?
I think it's probably a question beyond my remit, in all honesty. I guess, you know, you saw kind of midway through the COVID pandemic, when we had a lull in cases, the elective backlog, we really pushed forward on that to get ourselves through it and to move through that backlog, and you saw it start to come down again. But what we've really got is such a mixture of events and things in terms of whether patients were able to present to their GP and therefore get themselves onto the waiting list at the time. You know, it makes it very difficult to interpret. In my personal opinion, all I can see going forward right now is more people being added to that waiting list. We need to find a way of increasing our capacity while keeping patients safe. So whether that's the number that it ends up with by 2022, I don't know, but I certainly do see it increasing.
That wouldn't surprise me at all either, that that's probably the right order. In mental health, we've got 1.6 million people are on waiting lists currently, and that's growing. But we also recognise that there's probably 8 million who are in need of mental health services, that because of that 1.6 million and the waiting times involved, they're not joining the waiting list. So, you know, I mean, and I'm sure that's true in physical health, that people are thinking, I'll live with it if I can.
Yeah. Okay. So there's a couple of questions for you, Tim, actually, on sort of mental health and services. So there's a question about target procurement organization for mental health services, and whether you had any thoughts of who those organizations should be, whether that's CCGs, ICSs, mental health trusts, or local authorities, in your views.
Okay, I think if you look at where do we need innovation in mental health, we need innovation in wherever kids turn up. Yeah, so I wouldn't just go to mental health services, but we need innovation in therapies. Yeah, we need innovation in service delivery. We need innovation in training and training staff. We need innovation in self-help. We need innovation in peer support. And there are, peer support, for example, there is an organization that runs a whole national peer support network in mental, for kids with mental health. And most of that is online and so on. We need stuff about mental health awareness. There's a huge amount of ignorance out there, teacher training, etc. And one of the things that's happened with COVID is the rise of digital, which sometimes is the phone, using the phone for therapy, the phone for assessments, etc. But also video-based assessments, an increase in using online tools for therapeutic stuff. Now, my view is that what we're looking for is a blended approach that fits each individual. So, for example, if you have a child with autism, they actually prefer to do therapy and to do assessments online. In the main, so whereas there used to be a number of kids wouldn't turn up for an autism outpatient clinic, now you get about 100% turnout because they can do it online, they can do it in the privacy of their own homes, they don't have to sit in a waiting room. So there are lots of real positives about what the pandemic has forced us into, and use this as thinking through, look, these are innovations that we were forced to make. Let's take that further and see wherever we can how that can fit individual need. So and which organization, go to the CCG, ask them if they can help you with your innovation across different organizations. But I wouldn't just stick to where kids turn up in health services.
Yeah, absolutely. Thank you. So we probably have got time for a few more questions. There's one potential idea here, perhaps for you, Katie, on an innovation, and perhaps getting your thoughts on that. Would the introduction and evidence gathering of proven digital health technology that has the potential to save GP time in the checking and filling of routine blood tests and other assessments could be within scopes of what we're looking for this competition?
I'm not sure whether the question is about what's in scope for this funding, or it's about whether this would still be a good thing to do. In my opinion, anything that is going to save a GP time is a good thing to do. But ultimately, that falls, I guess, under the diagnostics part after the recovery of that. There have been other projects I can think of which helped GP surgeries, go through their entire patient database, for example, to pick out who required annual blood tests, who hadn't had certain tests done, you know, within a period of time, for example, and things like that. And those have certainly helped manage backlogs in the past, and they could definitely be useful in helping us, you know, manage those chronically ill patients who are perhaps not presenting to GP surgeries, or you know, need some follow-up, but we don't have the administrative time to be chasing them on a one-to-one basis. So in my opinion, yes, there would be, depending, I guess, on how far down the line the pilot was, as to whether it's eligible for this project.
Yeah, absolutely. And the team is welcome to come and talk to the program management office, and we'll talk a little bit, but we'll have a clinic in a few weeks to discuss about project specific questions. So we'll give you more information about that. Thank you, Katie. We had one specific around, for you, Tim, around childhood and sexual abuse. Do you think that abuse in childhood, specifically around sexual abuse, will lead to mental health issues? And do you think that the prevention of abuse in the first place would be the answer to that?
I think it sort of pretty much goes without saying that if you can prevent a mental health problem, you're better off than having to treat it. Let's make the answer a little broader. My clinical work is with homeless people, which includes a large number of people who have been, for some period of time, looked after. Yeah. So homelessness is incredibly common amongst people who start off looked after, much more common than in people who've had two parents. And amongst those that I see, I would say sexual and physical abuse are the norm, absolutely the norm. I rarely ever meet anyone who has not experienced some serious adverse childhood events. And I'd go so far as to say that those adverse childhood events are a major contributing factor in later adult mental health problems. Now, having said that, it's really important to understand what happens. It's been shown pretty clearly with things like maternal deprivation or other traumas in childhood that the care that you get after the event is a stronger determining factor as to whether or not you later succumb than the event itself. Indeed, I would go so far as to say that children who go through difficulty, serious difficulty, and are supported throughout that difficulty and afterwards effectively are probably more resilient than kids who've not been through difficulty at all. So it's complicated, the answer. I do think sexual abuse of children is very commonly, it does lead to later mental health problems, but not in every case. I mean, I do know adults who've never been in touch with mental health services who do, who have experienced that as a child. But I think it's very likely to lead to difficulty. I don't know if that's the answer, that people are after, but yeah. So yes, trauma and abuse of different kinds are very common amongst people with adult mental health problems, but it's more complicated than that, and needs to be seen in the context in which it's happened.
Yeah, completely. Yeah, it must be very complex. Can appreciate that. Okay, great. Thank you. I think we've probably addressed most of the questions here. I know that there's a few more, and some are a bit more program related, so we can address those a little bit later, perhaps. So what I would like to do is thank you both, Katie and Tim, for joining us today, for contributing to these talks. You're welcome to stay, but I appreciate you may have a busy schedule. So we're going to continue with our agenda, and a big thank you to you both for joining us and give us insightful talks.
Thank you very much. I will have to go.
Yes, thank you, Tim. Good to see you.
Bye.
Bye. Okay, so now what I would like to do is introduce you to Carol Spencer. And Carol is Director of System Partnerships and leading on the strategy for spread and adoption of innovation at the Innovation Agency, the Northwest Coast AHSN. She works with the Lancashire and South Cumbria ICS and the Cheshire and Merseyside ICS. Now, Carol started a career in the bank and finance sector, initially as commercial analyst before moving into management consultancy. And she's got more than 25 years of NHS experience with provider trust, commissioners, and in regional and regulatory roles as well. She's got significant experience in the planning and management of large-scale change as strategic development director of several large acute NHS providers across the Northwest, and is committed to the development of collaborative system strategies within the NHS. So Carol, welcome. Thank you very much for joining us today. And over to you. Thank you.
Okay, thank you. I think you're going to drive for me, are you, my slides?
Yeah.
So hello, everybody. I'm probably going to get into some practical information sharing and make some suggestions to you as to how your local AHSN and the AHSN Network can help you, both if you're considering applying for this call and even if you don't, how the AHSN Networks can support you in your corporate mission. So I'm just going to cover that little bit of information about the network itself in case you don't know it, how we can support you, how we can support you more generally, and a little bit about what we do around innovation spread mechanisms. So the next slide, please. So the AHSN Network is a network of 15 AHSNs that cover all of the English system. You can see them identified around there, and I understand that if you're not already connected into one of your local AHSNs, then Fanny Ann team can provide you with information related to the commercial link into that AHSN. In any regard, I would recommend that you did reach out to your local AHSN, and you can see us there, the Innovation Agency, covering the Northwest Coast, but we work closely with all of our partners, and I'll explain a little bit about that as I go on. Next slide, please. So what we're trying to do is we sort of sit in, you might think of us as the jam in the sandwich between both academic, industrial and clinical entrepreneur activity and the NHS and care system. So many of us who work in AHSNs have got combinations of commercial and NHS experience, and in my role particularly, I face my NHS and care system and hold a network of relationships across all parts of that landscape, so that when we have SMEs or innovators working with us, we can create very targeted, whether it be market access support or brokerage of next steps, but we can do that in a very targeted way relevant to the product and the context in which it's being sought. So we do try to act as that catalyst to create right conditions, to make it easier for particularly SMEs and clinical entrepreneurs to gain access to that complex fragmented markets. We will put people together because even within the NHS, we're notoriously disconnected between each other, whether that's between trusts, between programme boards, between specialty strategies. You've just heard Katie and Tim talk about two different strategies, and yet of being accepted and not rebuffed. And as I've said already, we do operate locally in our regional patches, but we collaborate nationally. So if something is being supported strongly in one region, it will be visible to everybody else. And so therefore, from your perspective, potentially give you market access nationally, even though you may concentrate your relationship locally. Okay, thank you very much. Next slide, please. This is just, I'm assuming you will get a copy of these slides, but this is just some information that the network impact last year. So in a sort of COVID year, we were still able to continue with progressing support to a significant number of companies in terms of their work into the NHS. Next slide, please. So what can we help you with if you're considering making a bid or as you go through the bid? So the first thing is, if you know what you'd like to bid for, but you feel you'd like partners, then we can help you to find those collaboration partners. They could be, as they're listed there, they could be academic partners, they could be providers, whether it's NHS organisations such as trusts or GP practices, but it could equally be pathology collaborations or some of the new emergent networks. And I think one of the things to be aware of is the NHS itself is changing its structure quite rapidly now. ICSs are coming into being as sovereign organisations from next April. CCGs, as we historically have known them, will cease to exist by next April. And trusts are coming together into provider collaboratives and primary care into primary care networks. And the AHSNs locally have got their finger on the pulse of where those changes are happening and who the, if you like, the leaders are in that organisation. Because the ground is shifting and it will be even more difficult for you to find a sense of who you need to be talking to and what role they're playing in this new emergent structure if you don't. So I would recommend that you use the AHSENDS in that way. We can also help you to source subject matter expertise. So it might be somebody like Katie, you've just heard, or Tim in some will be more developed than others, and some will have established contractual relationships with digital partners. Others will be more fluid in their development. And you will, if you have a digital technology that you want to develop in this call, you will need to know whether your product is going to align within the landscape, the digital landscape of the economy that you want to work in. And we can offer you that expert knowledge so that you don't go too far and reach a barrier that you could have otherwise avoided. So we can offer that. We can also help you with very practical transactional support for making sure your bid hits the mark. And we can help you to support going through from first stage review to second stage, whether it is critical friend or trial by jury, friendly rehearsal, whatever it is, we can help you with that. Very much focused on a relationship, and we like to think that we have relationships with our SMEs that last a long time, not just through single calls or bids, but over the long time period. Thank you. Next slide, please. I've mentioned this already, but we will be a critical friend, a supportive friend, and sometimes that doesn't feel that helpful at times, particularly if we're saying, you're coming at this the wrong way. I mean, I've got examples where a company has developed a benefits case and they're selling it to me on the back of what they think will be most successful. And what I know from my experience is that when I get to know the product, I realize that they're sort of downplaying the most important part, I think, of their product. And so we can help to shine a light on that and give you the confidence to go with the real benefits case and not what you think you're hearing in relation to the system and the way the system is talking to you in the early stages of your company development. After calls and in any regard in the long term, AHSENDS will support their SMEs with development of their evidence base. And I'll talk about our pipeline in a minute, that we hold the aggregate set or the repository of knowledge across all the products on a pipeline. So we will support you with that. And, you know, further on, we will support you with the commercialization of your innovation. So that could be in the commercial team. My colleague Mike Kenny is unable to be here today, but in our organisation, Mike has, he leads the commercial team and will support all of that. I tend to lead on the NHS market access support, you know, that can move from individual giving market access to individual sectors to increasingly thinking about strategic system adoption of those services and products that will make a sea change of productivity or access to a service transformation plan. So those big challenges, those boil the ocean challenges that Tim was talking about, you know, how do we actually bring that to bear? Some of those market access supports really require the market themselves or the NHS themselves to recognise that if they're going to make the most of innovations, whether they be technology or service models that are being developed, they have to change the way they work too. It's not a matter of giving, you know, a plug and play model that supports everything else they're already doing. It's much more likely to require them themselves as staff members to undertake material transformation in the way they approach their work. And that brings its own challenges, and we can support that, whether it be in the background or the foreground of product development. Next slide, please. Thank you. So I've mentioned that we will support you whether or not you're in a bid method or in an SBRI call. So we do, the AHSN Network holds an innovation exchange. It's on its own website. You can place your own product into that, and it will enter a process of evaluation and support. And there's a little bit of information there on that slide. If you'd like to look at that on the AHSN Network website, if you'd like to know more about that, please do approach your own local AHSN. Next slide, please. I've mentioned that we hold a pipeline of innovations. So this is where we're looking at things at a systematic level rather than individual product level. But we hold the whole AHSN network work together in a pipeline. So it's formed of many mini pipes, if you will. So there's the 15 of each for each AHSN. And then within those 15, there are also sort of pipes that can be labelled or tagged as, for example, we will have one for a point of care testing a group. There will be another one for mental health groups. So in other words, it's a database, and we're tagging innovations across that life course from invention or discovery through to the development, which is really what this SBRI call is about. It's really about that step 4 solutioning to proof of value, and then ultimately deployment or spread into the market, whether it be through effective sales and development for a company, or indeed turning it the other way, whether it's about the NHS adopting whole-scale decisions to adopt a product or a service model across an ICS. And you'll see that there's a role for each of us, really, from commercial partners in terms of invention and discovery, local health and social care partners in terms of development support, but also ultimately they are the buyers of goods. Academic partners provide a standardized evaluation and evidence generation and credentialing method. And then we have national partners where, you know, such as people like Tim and Katie, who will identify whether there's a national interest for any of those products that are on there. But it's also where things like the NIA system sit, the SBRI system, and a few others that I'll mention in a minute. And they've got clinical innovators, and I would put social innovators in there and third sector innovators. So innovators that are developing service models that hit the criteria of increasing productivity, increasing safety, reducing health inequalities They may or may not have digital or technology components within them, but are nevertheless very, very welcome on our pipeline. So I would encourage anybody who isn't connected into their AHSN to talk to them, and then what would happen is your product would be assessed against its maturity on this pipeline and then is visible. So when my local system comes and talks to me and says, we'd like something to help us with a transformation program for, and this is a real one, but for transition and mental health, transition and adult ADHD, then one of the things we're able to do is to look across our pipeline to curate what available innovations might, in combination, be able to be pulled together towards to create a digital platform to create a transformational future. So we use it strategically that way. And obviously, if you're not on it, we won't be able to see you. Next slide, please. And then just finally, we are talking about SBRI program today. This is an important one of those national partners that we support, but also we want to see the products that are going through there on our pipeline. And just for your own information, there are a number of others of those. And this is where the SBRI program itself can be a really hugely important support and development method towards further and onward spread and adoption initiatives that the NHS sponsors. And a few of those are here. So one is the AHSN Network has a set of national programmes that NHS England commission it to spread. Those national programmes are often selected from the best of available other programmes such as the SBR programme and the National Innovation Accelerator programme. So it's a really important new seedbed for potentially wider national spread. The MedTech funding mandate is a relatively new policy, but this is where devices and technologies are being assessed for national adoption. So they could again come through SBRI or other routes, but each provider or purchaser in the country for this list is being asked to ensure that they are commissioning or buying the products that are in this list. So it's almost, comply or explain. If you get into this list and it's your product, then you should be really having great assistance to pull towards national spread. Rapid uptake products is a collaboration with NICE. Tends to be more in the medicines area at the moment, but that's not a restriction on the programme. It simply is where the current portfolio set is. And that's again about saying for those products with NICE approval that may still be suffering from a lower or a slower than expected uptake, this is an acceleration of those products using the delivery, using the AHSN Network as programme management delivery partners, so that each system, each ICS system knows what's expected of it and is supported to implement the uptake. And then we've talked about the National Innovation, the NIA award winners. So people who submit for that programme, 12 innovators are selected. There is obviously several years of alumni as well. And their products are selected for scale and are particularly supported with both commercial and technical and NHS support from both the AHSN Network and other bodies within NHS England. So there are a number of other programmes that support or are complementary to the SBRI programme and that the AHSN Network supports. So I think that's it, Fanny. I think that's me done. Yes, thank you very much.
That's great. Thank you very much, Carol, for discussing about the support the AHSN is able to provide to innovators, particularly around the implementation and then further on the adoption of those innovations and the sort of scaling up. but also some of these opportunities that you can provide for signposting and linking those innovators. Really, really interesting to hear. We'll come back to Carol a bit later in a short moment with some of the questions. But I'd like to move on to our sort of final speaker for today. And I'd like to introduce you to Zee. Zee is a Senior Program Manager in the Innovations team at the SBRI Healthcare Program Management Office. And he's going to give you some information about the competition, the program's assessment process, and the criteria, as well as the steps involved to apply to the program. So Zee, welcome. The floor is yours.
Thank you, Fanny, for the introduction. Good morning, everyone. Now that we've heard about the challenges on how the AHSN can support your innovations, I will just go through the application process with you and provide some more practical guidance on how to complete the application form and the competition timeline as well. So this is a one-stage assessment process. The application portal opened this morning, and you will have about 7 weeks to complete it, closing on the 13th of October at 1 p.m. So anything submitted after the 13th at 1 p.m. will not be considered, so please do bear that in mind. Following submission, each of the application will be looked at by 3 independent reviewers with appropriate clinical, commercial, or implementation expertise. The applications will be shortlisted based on the quality and will be invited for an interview with the selection panel on either the 13th or the 14th of January. You will be contacted with a time and instruction for your interview towards the beginning of December if you were shortlisted. And if successful, the SBRI Healthcare Program Management Team, the PMO, will conduct a series of due diligence on the projects with you before contracting. And as mentioned previously by Mike, the projects can last up to 9 months, and each project can request up to £500,000. Next, please. The application will be scored against the criteria that should be coming up, if you can't see already. So the criterion is weighted, so ranging from 5 to 20%. I'm not going to go through this in detail with you, but all of this are available on the competition website in the invitation to tender document. But there are some of the high-level information that you really must provide, including how your proposal addresses the brief and how you would manage some of the risks. The team composition and how you would involve patients and the public in the project, as well as the intellectual property management, as well as the adoption strategy within the NHS and within the wider market as well. So like I mentioned, all of this are available in the invitation to tender. So please do read over that ahead of time and before you start the application. Next, please. There are a number of documents that we have online. These include the challenge brief itself, and there is a separate challenge brief for each of the challenges, the associated guidance on how to complete the application form as well, and what kind of information we would expect to see. There is also a template application form as well that you can see online, but you do have to complete the online form through the application portal rather than completing the PDF version that we have on the website. So please don't post anything in. And then we will upload a series of FAQs from the webinar onto the website as well, including anything that we aren't able to answer today. There is also the competition timeline that's listed here. And again, all of this is available on the website. So and we will circulate the slides and the recording towards the end of this week or beginning of next week. Next, please. So onto the application portal itself, when you go onto it, you will have the option to either log in to an account if you haven't already with us, or register for a new one. Next, please. When you click, so once you're inside your account, please go to the left-hand side of the portal and go on to manage my details. So some of these, to make sure all of the information there is up to date, so some of which will be this information will be used to populate the application automatically. So once you're ready, click on the highlighted link here in circle and to start a new grant application. Next, please. There may be a number of funding rounds that are available or currently open, so please search for the appropriate competition. So for SBRI Competition 19, it is labeled as such, which is for mental health inequality, as well as NHS reset and recovery. It should have the appropriate closing date on the 13th of October, and you can just click apply on the right-hand side of the panel of the row to start your application. Next, please. The application will contain a number of question mark icons in blue circles. So these will provide a description of what should be provided in each of the boxes. Please do use them as guidance to help you complete the forms. There will be additional information that are also available in the applicant's guidance document, which is linked here, but also on the application, the competition page as well. So please do use all the information available to you to complete applications, and you can save and close applications at any time and come back to it. It is mandatory that you complete all of the sections within the application form before you can submit it. So I'll refer to section 5 specifically, which is for the team and clinical partners and subcontractors. So you can search for their name and add them to the application. There are 3 types of members in this section: direct team members who will contribute to the project, clinical partners, and also subcontractors. A description on the contribution of each of the members that you have added must be provided. And please note, all of the members that you add will need to have an account with us, and these must be approved by a member of our office, which can only happen during working hours as well. So please encourage all of your team members and partners to sign up for an account if they don't have one already as soon as possible, as any delays to submission caused by late sign up will not be accepted as well. So and generally that is the biggest hurdle that we see when an application is started a little bit too late. Next, please. If you have added any team members, clinical partners, or subcontractors, you will notice that you can't actually submit. That button is not actually available to you, even if you have completed the entire form. This is because the people that you have added must approve their participation in the project and approve the application as well before you can proceed. Next, please. So if your team member, once they have registered for an account with us on our portal and log into their own account, they can go into their My Co-application section on the left-hand side. Click on this, and there should be an icon towards the right-hand side that will allow them to view any applications they were included on. Next, please. Once they've clicked on that, they will see a page like that displayed here, where they can confirm their participation and approve the application as well. So once that's completed, you should receive a notification. Next, please. Once all of the members, team members, clinical partners, and subcontractors have approved the application, the applicants would then be able to submit the application, and you can see here the submit button would then be available. Next, please. So, just to say, the SBRI Healthcare PMO will host a Q&A drop-in on the 2nd of September. So I think the Eventbrite page for registration will be available after the webinar today. So if you have any specific questions regarding your project, you can come to us, and you can talk to a member of our team in a bespoke private session then as well.
Great, thank you, Zee. Thank you very much. So I think we've covered quite a lot about the programme, given an overview at the beginning, the assessment, application process, and a lot of insight about this particular competition. So now it's time for our Q&A, and I'd like to invite Mike and Carol back together with Z to answer some of our questions, please. Oops. I can hear you, perfect. Okay, and Mike, I think we can hear you, we can't see you yet.
I think the host needs to activate my video.
Oh, yes, yeah.
There we go.
Perfect, brilliant. Okay, so we've got a number of questions, and I think we've got some on the AHSN that we can also cover with you, Carol, and then some more general questions. So there was one, Carol, about from Paul. Is there a conduit to engage with the AHSN, but at a national level?
So I think there is the AHSN Network Innovation Exchange portal. So if you look there, if it's a product placement, if it is trying to develop a relationship nationally, then we tend to do that locally and share nationally. And that's to stop companies feeling they've got to go around all 50. So we sort of self-organize that way.
Yeah. And then I guess you've got some of the links that you've got that can be sort of best suited depending on the innovations.
Yeah, absolutely.
Yeah, perfect. Okay, great. Thank you. And another one around funding for the AHSN, and perhaps an open questions about what would happen to the AHSN when the EU funding ceases.
So our funding isn't from the EU. It's from NHS England and NHS Improvement. We do have a small some AHSNs have European Regional Development Funding contracts, but that's not the main business model that we operate. So we would be more concerned if NHS England were not going to renew the licence, and we hope that they will.
Yes, definitely. Thank you for the clarification. I've got one perhaps that I thought maybe, Mike, you may be able to help on this one, because it's a question related to NHS Digital and NHSX initiatives. And how does the SBRI program initiative aligns with the NHS Digital and NHSX initiatives and sort of prevent any duplication, I guess?
Well, there was the big NHSX AI funding that went out, and you know about this funding because you were closely involved in it. And there's quite a lot of funding there. There's still a lot more funding on the AI side. I think these challenges are a little bit broader than just AI and digital. It's digital is one area, but certainly for the children and young persons' mental health. Certainly, digital will play a part in terms of looking at how we reset and recover. But it's this competition. If you look at the sort of Venn diagram of intersection, the Venn diagram would be AI and digital. The NHSX competition is about AI, and you may have some things which weren't funded there that you'd like to bring forward. But there is a minor overlap, but the other areas we cover with children and young persons' mental health are so broad that I don't think there'll be too much of a clash.
Could I, in addition, you might be interested in looking at NHSX as starting to issue a number of playbooks, digital playbooks, in relation to outpatient transformation to a virtual setting, because we have the virtual consultation, but that only takes you so far. How do you then connect different models and devices and so on into that? And the playbooks are non-product specific, typically. So take a look at those because I think that offers lots of opportunity.
Yeah, lots of advice and guidance. The VOVC one as well is really interesting one.
Yeah. Okay. Thank you. So we've got another question on the AHSN and how does AHSN Network programs relate to Health System Support Framework, HSSF?
So that's a procurement framework. So we don't directly relate to it. I mean, obviously the government establishes a number of, or Department of Health and Social Care, a number of procurement frameworks that suppliers can get onto, that then makes procurement locally more straightforward if our partners choose to procure that way. Our national programs are not procured commercially by the NHS. We are part of the NHS, so we are we have national delivery programs, and so we're not connected to a procurement framework in that way. I'm not sure if there's a sort of question underneath the question.
Yeah.
No. quite specifically about this particular framework. Yeah. If anything comes up, Carol, I'll bring it back. Yeah. Yeah. Okay, perhaps the questions for you, Z, around some of the criteria. So could you clarify criteria 6? I'm just trying to bring back the slides to pick it up. Please, because given what Tim said about looking at other places where young people can be found, can the innovation be entirely outside of the scope of an NHS service?
I think potentially, because part of our challenges, especially under challenge one, well, actually both challenges under the mental health part, is that we are looking for early detection and prevention of mental health problems in the CYP population, in a number of different settings, including community and school setting as well. Yeah. So if there are particular innovations or services that can be provided that can address those problems, then they would be eligible and would be assessed as such. So it's not just about NHS adoption per se. Obviously, we are looking at a wider ecosystem and the landscape on how to address the bigger problem in order to reduce the burden and increasing the efficiency and the quality of mental health support available to these people.
Okay, great. Yeah, thank you, Zian. And I think there was a question perhaps related to that. There's a lot of discussion around NHS trust and tech that's already been adopted by One Trust. And then perhaps what about technologies that are from patient being cared for in the community? So perhaps more of a social care approach and have been adopted by local authority because local authorities are currently responsible for social care. So would that be this type of technology be eligible for the NHS Reset Challenge?
For the Reset Challenge. I would think so, because part of the again, as part of the brief as well is and I think a lot of information will be available then, more of a detail anyway, is that we are trying to address a problem on how to reducing the workforce pressure. So if there are tests or innovations that can be rolled out in a more of a community social care setting for the Reset program, then yes, that would be eligible for the competition as well.
Great. Okay, thank you. Just looking at some other things, and I guess there's a question we might want to answer, perhaps a bit more broadly speaking, about patient and public engagement, more from perhaps a program side. So, if a product has been developed in conjunction with NHS clinical, tested in a particular locality with some user feedback gained through that. But for reasons of IP and commercial sensitivities, I've not had public or patient involvement in the R&D process to get to the final product. Would they be still eligible to receive funding for at-scale testing via this program?
So who wants to answer this first?
I mean,
I can make a start. I can make a start on it. And then if others can chip in. So for the mental health challenge, at least we are looking for things that have been co-developed with patients, because what we've heard from the AHSNs and the subject experts is that if you are developing something for children and young people, you really should have taken their consideration during the development of whatever it is that you're putting forward, because what they would think is relevant for that age group might be very different for someone who is even 2 or 3 years older or younger. So I think PPI is very important for the mental health aspect. For the NHS Reset and Recovery, I think that can be probably looked at in a bit broader, where if the innovation is addressed at particular different type of specific workforce, or more of a system approach rather than directly patient facing, then we may not put as big an emphasis on the PPI element during R&D, but may require more stringent PPI, before it is rolled out or implemented. Mike, I saw you nodding and shaking your head, so please do chip in.
If you develop something purely in isolation away from patients and citizens in which it's being impacted upon, it's probably going to have less less value. I can see it being in the second part of your challenge, as you mentioned there, Steve, but certainly in the first part, you really have to involve patients, citizens. You have to involve the carers of patients as well. Technically, I don't really buy the reasons of IP and commercial sensitivity, because you can get NDAs, non-disclosure agreements, you can get CDAs, confidentiality disclosure agreements in place with whoever you're talking to, and you can physically contract with them, so you maintain that confidentiality. So, and we've done that before and put that in place. So that shouldn't be a barrier to you to engaging with the people who A, will benefit from your service, and B, pay for your service as well, because we're all taxpayers. So I'm a real keen pusher of about 3 things at SBRI: levelling up and moving things across the country, 2, equality of access for people, and 3, involving citizens and people who pay for the service in the development of innovations for their care. So I'd encourage and really push it.
Yeah, absolutely. And any questions, we can always follow up with the SBRI team on PPI more specifically, or way to sort of go around these sort of IP commercial sensitivities.
There's ways.
Yes, yeah. Perhaps we've got one more question. I know time is running out. So it's from Jim. Is there a view on taking a technology proven in the field of new ways of working as part of that research called New Ways of Working in another country and getting it successfully working in the UK? And that's for a new UK SME. Maybe something for you, Mike or Ozzy.
Yeah, I was just trying to see where the question popped up then. So I can't see that on my list here.
Yeah, and so it's from Jim, and I think that's really quite specifically around, you know, other countries. And I think from my point of view anyway, it's really about building the appropriate evidence to enter the UK market. So that's the critical part.
Yeah, the UK market is, like all healthcare markets, having lived and worked in lots of them, the UK market is particular, it is different. So if you have some innovation which you're bringing from outside, you want to bring to the UK, you're going to have to show how that's going to benefit the UK market, the UK NHS. I think, Jim, I think I would, if I were you, take advantage of the drop-in centre or drop-in call on September the 2nd between 1 o'clock and 2 o'clock, links in the notes, and have some one-on-one and share that information with us, and we can probably guide you a little bit better.
Yeah, I think that's a good idea. And I know we've got Carol here, but we know the AHSN can really help you with you know, understanding what data, what evidence you need to get to the UK market. So it's also something to keep in mind. And I don't know, Carol, if you've got anything to add, but certainly going towards the AHSN and your local AHSN to have this discussion.
Yes, I mean, certainly every AHSN has a slightly different you know, area of focus, but certainly in our AHSN we operate, for example, a Bridgehead programme, which is a European funded programme for you know, bringing European companies into the NHS context, and similarly we offer one for a global access. The question is, as Mike probably alluded to, it's things like we hit things like price points and things like that fairly quickly, but there are also some great stuff out there. Great ideas.
That's great. Okay, brilliant. Thank you. So I think it's probably time now to draw close to our Q&A session. And if there's any further questions, we can answer to them later, or in our frequently asked questions document that we'll publish online. But please do contact the SBRI Program Management Office for any questions that you may have about the program, the competition, any project-specific inquiries as well. So please do pop your questions. Z mentioned it already, but we'll be holding a Q&A clinic where you can have the opportunity to join and have one-to-one session with the Program Management Office, and that will be on Thursday, the 2nd of September at 1 o'clock. So competition 19 is opening today. We'll close on 13th of October. Feel free to join us or on the 2nd, or send us an email to the team at sbri@lgcgroup.com. So one final note for me, I'd like to really thank all of our speakers today. Thank you very much, Mike, for joining. Tim and Katie have already left, but really grateful for their participation to this webinar, and Carol as well for joining us. I know he's taking time away from busy schedule, so I really appreciate your contribution to the session, but also to the competition. really pleased to have had you on board. Also, a special thank you to the SBRI Program Management Office for preparing the competition and for the session today. And thank you to all of you for attending this webinar. We hope you find it useful. There's a lot more information on our website about the competition and specific challenges, and we hope to hear from you soon. Thank you very much, everyone. Have a great day, and see you soon. Bye-bye.